All right, everyone, let's go ahead and get started. Good morning. Thank you for joining us for the Healthy Transitions Colorado December 2015 webinar. My name is Kristen Paulson, and I'm with the Center for Improving Value in Healthcare, and I'm really happy to be here with you today as we talk about ways to improve patient education and outcomes. Healthy Transitions Colorado is run by operating partners, the Colorado Healthcare Association, Telegen, the Colorado Hospital Association, the Colorado Medical Society, the Colorado Rural Health Center, the Colorado Behavioral Healthcare Council, and Health Teamworks, and it's managed by the Center for Improving Value in Healthcare. HTC is a collective effort focused on aligning and accelerating the existing efforts to improve transitions of care for all Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, visit our website at healthytransitionscolorado.org. So I have a couple of things before we get started. The phone lines have been muted and will remain so throughout the webinar. We're going to be using the chat feature in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Any questions or comments you have for the presenter will be answered and addressed during the question and answer session after the presentation. This webinar is being recorded, and we will post it to the HTC site so you can access this information again at any time without cost. I also want to quickly mention our upcoming final Learning Series Symposium, Fostering Patient and Family Engagement, which will be happening on January 15th. The focus will be on collaborating with patients, families, and caregivers in all settings and across the full continuum of care. Registration is open right now at healthytransitionscolorado.org. So I'd now like to introduce our guest speaker, Dr. Sean Gogarty. Dr. Gogarty is a high school teacher, now turned emergency physician and EHR expert. 2 decades in the ER provided unparalleled insights to the entire healthcare system. With deep understanding of clinician realities and patient necessities, he founded Inscendent. The objective was to improve patient outcomes by making it easy for clinicians to better educate patients using automated digital communication and multimedia. Sean, I will hand the presentation over to you.
Thank you, Kristen. So appreciate that introduction. These webinars are kind of a marvel. Kristen and I were talking about them before we started, just the ability to contact so many people, which is great, but it's a little disembodied, so I always feel a bit odd. I hope everybody will interact at least by asking questions. So quick kind of run through of where we're going. I don't think I'm going to take the full 60 minutes. I don't want to. That'll be your Christmas present. But just so you know where we're going, I've tried to outline the presentation to somewhat parallel my own experiences in failing to educate patients and how I've tried to come up with a way to better educate patients. As Kristen mentioned, I was a teacher. I graduated from college with a bachelor's in earth science, secondary education. And after about 4 years of teaching, I decided I'd trade in uncontrollable teenagers for uncontrollable drunks in the emergency department. I've now been doing that for about 20 years. And unfortunately, I think my background as an educator made me think I was educating patients well. And it wasn't until we started doing patient surveys that I realized I was really failing, and those were consistently low scores, not just for me, but really across the boards in educating patients about their health care, their conditions, and things they were needing to do about it. And as mentioned, that's basically what led me to found Inscendent. I don't need to belabor this point. We're all too familiar with healthcare bad outcomes. But I do like to just make us think about comparing it to other industries. And if you were producing any other type of product or providing any type of service, and you charged as much as we do, and you had 1 in 5 failures, it would be a company for not very long, I would suggest. You know, high readmission rates, huge costs. ER is probably also extremely overutilized, as you're all familiar, and I personally am familiar, to the point that I know so many people and have seen so many of them naked, I'm actually afraid to go out in public. So where's the problem lie? There's tons of contributing factors, no doubt, but I like to keep things simple, and I think actually is pretty simple. I'd personally like to blame the patients for all the bad outcomes, and that's just a joke, of course, but the reality is, if you think about it, if the patient doesn't understand their care, there will be a bad outcome. And in fact, the outcomes are ultimately dependent on patients doing something correctly. And that's outside of the healthcare facilities for the most part. One of our anecdotal experiences that was quite telling, we had a returning COPD patient back in the hospital over and over and over, the typical readmit story. And when she finally watched a video of ours about how to use an inhaler, she said she didn't use hers that way. So in spite of tons of clinician contacts, she still didn't know how to use an inhaler, and that, of course, was contributing to her bad outcomes. I think it's important to remember that the health literacy rate in the United States is actually estimated to be at about a 4th grade level. In the United Kingdom, they did an interesting study just looking at patients, not patients, but just general population identifying body organs like lung, heart, liver, kidneys, and less than 50% of the population were able to do that. Now the other, to me, half of the problem, maybe not half, but the other part of the problem is clinicians. So I'd like you to look at that formula at the top of the page, and I wish I could poll everybody, but in this setting we can't. How many of you know what that is? I used to teach junior high and high school math, so I actually do know what it is. It's the equation for the slope of a line. And if you went and talked to any junior high student that's taking that type of math right now, they'd probably know what it is. And we've failed to remember that the things we talk about as healthcare providers excuse me, are very common to us. And so when we're talking about pancreatitis and pyelonephritis and acute myocardial infarction and all of those things, they mean something to us, but they actually don't mean anything to our patients. And as noted there, just leaving hospitals, it's barely half of the people leaving hospitals understand what their care was all about. So let's talk about some solutions. I think what's important to identify in figuring out solutions is, what do people want? There's things they need and there's things they should do, but we should act on what they want in order to have effective solutions. And probably all of you have had some sort of experience excuse me, with EHR or EMR deployments. Most of you are probably cringing like I am, because I've actually been through about, actually I'm going to be starting my 3rd one here shortly. And that is an example of trying to apply a good idea, but not in a way that the user wants it. So when you think about multimedia and digital communication, that's what people want. 4 billion YouTube views per day. There's only 7 billion people in the world, and yet that's where people go. They want and like video, and they like to communicate with email and text. They don't really like to answer their phones per se, and so we need to keep that in mind as part of our solution. The other thing we need to remember is that Healthcare continues to fail by explaining things with words and handing people paper. I took this straight off of a website that is for patients about COPD. I ran these words through what you can see there, the Flesch-Kincaid grading program, and it identifies how many years of schooling you would need to really understand this explanation, and that's the 16 there. But that's the kind of thing we keep doing in healthcare and we need to avoid because the words just aren't helping patients. What we need to use are images and videos. I started doing this as a solution to my problem by simply taking a set of pictures and laminating them and carrying them with me in the emergency department. And things like a picture of the organs inside a stomach and being able to show what an appendix is and where it is made for a much easier time of explaining things to patients and a much more satisfying explanation for the patients. Couple data points there. Images can improve learning by 400%, and they're processed 60,000 times faster in our brains than text. And as noted there, text goes in the short-term memory, soon to be forgotten, and images go in the long-term memory, hopefully to be remembered. This was a really powerful study about videos. And if, you know, the old saying, a picture speaks 1,000 words, if you think about a video being thousands of pictures, you realize just how great videos are. This was a study of cancer patients, and they were mostly terminal, if I understood the study correctly. They were divided into two groups. Half of them received instructions verbally about life-prolonging care, things like CPR, chest tube, or feeding tubes and ventilators. And the other half watched videos about life-prolonging care, like CPR. And isn't it interesting to note who chose not to have those life-prolonging measures initiated? And I think if you think about it from a healthcare provider standpoint, you'd realize that's probably what you would choose, and the reason you would choose that is because you've seen it. But if someone talked about it, it just doesn't make sense. The other great value of video for the clinician is that it saves a ton of time. I've actually had patients be very grateful for me showing a video, and yet I'm thinking how grateful I am that I can be doing something else while they watch the video. The digital contact is powerful on several levels. Number one, again, it's what patients want and it's what they do, but it also allows us to reach them outside of our contact point. In other words, before and after their visit to a healthcare provider. So while we as healthcare providers too frequently keep talking to patients and giving them paper, I believe what they would really be best served by is multimedia delivered to their handheld devices and personal computers. And that's what led us to developing the 360 Engage app as part of our company called Incendent, utilizing all of those things we just talked about, the multimedia, the digital delivery, making enrollment easy so you weren't burdening clinicians. And so in the end, it was not just a matter of making things better for patients, but also making it much easier for clinicians. We started by taking all the stuff that doctors and nurses say, again, those relatively worthless words, and we converted them into videos. Now, I think one really critical issue here, whether you ever choose anything we do, is that we learned very quickly that actors can make really convincing doctors, but doctors are really bad actors. So putting a doctor in front of a camera as the video really didn't help the patients much. We produced very brief, engaging videos using actors and animations so the patients actually wanted to watch them. And we never let them go more than 3 minutes if possible. YouTube did a great study, and it showed that of those 4 billion views per day, very few of them ever watched for longer than 3 minutes. And so that was kind of the time frame to engage a patient with video. The other, well, I'll mention it later. So we took those videos, we took a bunch of images, and initially we put it in an app, and that app's available. And the app gave any clinician the ability to share images at the bedside, explain things like Johnny's ear is hurting, look at where it hurts, or this is where an appendix is and you don't hurt there so you don't have appendicitis, or any of those types of things were enhanced with these images. The other thing you could do with the images and videos is you could then easily share them, as mentioned earlier, digitally. Put it in an email, put it in a text, and send it to that patient. In my setting, the emergency department, this is really valuable because when patients are ready to go home, they're not ready to listen to me explain anything. I've probably given them morphine and Phenergan. They are sick. They're tired. They've probably been there too long, as we all know, with emergency departments, and they just want to get out of there. Now, the next morning, when they wake up and they got a bottle of pills that I prescribed, then they're interested, and they're interested in understanding what's going on with them, and that's when that email can show up and help guide them so that they're doing the right things and having better outcomes. One study was done where all they did was contact patients 24 hours later by email or phone, didn't matter. And in that study, there was also an 8 to 10% increased satisfaction rate with the patients. After producing the app, we realized that, unfortunately, a lot of us doctors and nurses still had trouble changing our behaviors. Surprise, surprise. And so we said, how can we make it even easier to get this multimedia content to patients? So we developed a software program that allows you to take any type of report from any EHR in an Excel form and drag and drop it into our program, which is web-based. Once you've dragged it into the program actually auto-selects a care path, a set of videos and emails specific to that patient's diagnosis. And not only does it select it, it then automatically sends those to the patient in a timed manner. From the emergency department, that might be a single email about their ankle sprain, but still appreciated. Or in the case of discharge from a hospital setting, it might be a series of emails about their COPD and things that they need to do to stay out of the hospital, especially for the next 30 days. But that approach has really helped improve the ability of engaging the patients without adding any extra work to the physicians or nurses in any setting. Now, the kind of creepy part of this, I guess I'll say, even though it's really powerful, is that once you have multimedia to share with patients and you share it digitally, you have the ability to monitor their activity. And so with our program, you can actually take and send out, as I showed in that previous slide, a series of video emails. And then you can see exactly what Mrs. Jones did with those emails and videos. Did she open them? Did she watch them? How much did she watch them? And this becomes an incredibly powerful way to be more efficient in taking care of patients. For example, you may have 50 patients that went home from your hospital yesterday, and you think all of them need to be called, but some of them really don't. And with this approach, you actually know which ones don't need to be called, and you can markedly reduce your workload in dealing with that group of patients. So does it all work is the big question. Did my journey to fix my own problem have any good outcomes in terms of trying to fix the real world problems? We tried it at Parkview first because, of course, that's where I work, and that was in the emergency department. Not just the flip book, but actually the videos as well, and sharing them with patients. And one of the places we found the most success in the emergency department was in helping with informed consent. One that is consistently used is TPA for stroke. And as probably, I'm sure most of you are familiar, TPA for stroke has a benefit. It's not huge, but it also has some significant risks, including death. And so there have been lawsuits both ways for giving it and for not giving it in the setting of stroke. Now, this is a really time-sensitive thing, and so what we've been able to do with TPA for stroke in the emergency department is have family and patient watch the video while the nurses and doctors are managing the medical condition. And that video then becomes a legal document for making sure that you truly informed the patient about the risks and benefits in a far better manner than any sort of charting or verbal documentation would do. And then additionally, we've used it to explain diseases, medications, and even things like you're getting a CAT scan, which to us is something very familiar, but as we've shown it to patients, they were very grateful just to understand what it was and made it less scary for them, improving their experience, the quality of their experience. After we had been doing it in the emergency department, we were invited to help with the endoscopy facility at Parkview. They do they're approaching 8,000 endoscopies this year. And they had as high as a 17% no-show rate. In spite of trying to make calls to patients and involving lots of people in the process of reaching out. So we simply took some videos about endoscopy, conscious sedation, and bowel preparation, put them into a series of automatically delivered emails, and enrolled patients into that process. And so they would get these not just instructional videos, but also serving as reminders to show up for their endoscopy. And I looked at the numbers for last month, and the no-show rate was 4.2%. Obviously a marked reduction from the previous high of over 17%. Now granted, we are not able to get every patient's email, but what we found is that every patient that has an email that we enroll in our program needs no further contact. They don't need to be called, and their no-show rates still stay down about 4 and 5%. So if you had 100 patients and we got 50% of those emails, you basically just cut workload in half by utilizing multimedia and digital communication through the care path. The other place we did a similar thing is in the Joint Center. We have a Joint Center at Parkview that does about 450 hips and knees per year. And our catchment area is huge. It's literally thousands of square miles. They put on an excellent class preoperatively, but unfortunately, there's miles and miles of travel for lots of the patients. By incorporating a series of pre-operative video emails and also post-operative, we were able to reach a much greater percentage of the patient population and actually have them very engaged in their care. In spite of there being an average age of 65, they wanted the emails and they wanted the videos, and they became much more active in their care. The first year we did it actually helped Parkview get Joint Commission certification. One of the surveyors said that the videos were actually one of the strengths of the program after they awarded the certification. Finally, the other place that I feel most excited about in terms of success is what we call our Transitional Care Center. Parkview had taken on the role of trying to contact all patients post-discharge, but they had disseminated that out amongst all the nurses. So if patients went home from your unit today, it was your unit's responsibility to call them tomorrow. In principle, that's a great practice. In doing it, it doesn't turn out so well. As you can imagine, if you haven't tried it, lots of unanswered phone calls and lots of staff too busy to even make the phone calls most of the time. So I joined forces with the home care director, and she and I put together a transitional care center proposal to Parkview. They gave us a whopping 3 FTEs to manage about 25,000 patients. Now, the only way we could do that realistically and effectively was, of course, to involve the use of multimedia and digital communication, sending patients these automated care paths about their diseases. And when we did that over a 6-month period, we were able to reduce the overall readmission rate at Parkview by 25%, and ours was already one of the lower ones in the country. So we were quite excited about that success. So ultimately, I believe we will have a very difficult time trying to make clinicians better teachers and patients better students. I believe what we need to embrace is the power of multimedia to educate patients and deliver it digitally to make it easier on clinicians, and also then allowing them to monitor patients' behavior so that they can be more efficient in their utilization of resources and ultimately have much better outcomes. Thank you.
Thank you, Dr. Gogarty. We've got a question right now from Betsy Duckett. How do you know which patients don't need to have that physical phone call?
So within our program, we make it really simple. You can go on a list of patients that you've sent emails out to, and based on parameters that you set up, the patient will have a red, yellow, or green dot next to their name. And if they have a red dot next to their name, it means they didn't do anything with the information you sent them. If they have a yellow dot, it means they did some things. You know, maybe they opened 1 or 2 of the emails and watched part of a video. And of course, if they have a green dot, then you have an engaged patient that you likely do not need to call or do anything with. Does that answer the question?
I think so. Betsy, just let us know if you have any additional questions. And for everyone on the line, please go ahead and enter any questions or comments in the chat box. While we're waiting for that, I'm going to go ahead and take presenter's prerogative and ask a couple questions myself.
Okay.
Can you talk a little bit about what you're seeing overall in trends and moving towards multimedia? What is the uptake like? What are the responses from doctors in using these new methodologies to reach out to their patients?
Well, as I mentioned with the TPA video, for the physicians in that setting, it was like a huge relief. because they were afraid of getting sued to do it or not to do it. And by giving them this powerful tool that did their job for them, if you will, and did it better, and also gave them, essentially this complete document of informed consent, they really received that well. Now, if I had to teach them all how to utilize multimedia or produce multimedia, yeah, there's no interest there. But that's where, we've tried to step in and help. But it generally has been well received, but changing behaviors is always interesting, and that's why we've tried to make it really easy so that you could even mass educate people, if you will.
Great. We do have a follow-up question from Betsy. Do you have patients sign a HIPAA release to participate?
Yeah, I appreciate that question because that's a critical one. HIPAA requires you to tell patients that if you want to communicate with them via email, that's completely fine, and it does not have to be HIPAA compliant email or secure. You can use Gmail, Hotmail, all of those to communicate with patients as long as the patient is aware of that. And as long as the patient knows that, Gmail and so forth can be hacked and people can find their information. The way we've approached that at Parkview is simply as part of the privacy policy. It's included in there. Other places have simply just talked to the patient and documented that as they're signing in and as you're getting their email address. And then we have another way that we can do where you send the first email has no HIPAA information. It simply says we would like to send you information using the email you've provided, which could be hacked. If you want to do it otherwise, then make another selection, and we have a portal that is HIPAA compliant. There's all sorts of options, but ultimately, most people are pretty comfortable just taking it in their regular email, and they're not worried that their neighbor could hack into their email and find out that they're doing, a colonoscopy or whatever.
Great. Thank you. So I've got one more question for you. If there are any other questions online, please, again, feel free to enter them in the chat box. So have you encountered any resistance from patients to use this kind of alternate communication method?
We have done it now with thousands, I think I can say. Yeah, definitely thousands of patients. And we've had one or two sporadically that have just been anxious about the regular email, and then we've just provided them the information, over a secure portal. So very, very little in that regard in terms of resistance. On the other side, we've actually had 70-plus-year-old patient who, when she found out we had videos about her hip replacement that was coming up, she would actually drive to her sister's house and had us deliver the emails there so that she could view them. She didn't have her own computer, but she very much wanted the videos to help get her ready for the procedure.
Great. We've got one more follow-up here from Betsy. Do the patients that are participating know that you can monitor their activity on the other side?
That's all just part of what you want to share with them. But yes, that should, and we would expect every organization to do that as part of the explanation as it goes out.
Great. All right. Oh, we have another one here. Where do you see this type of engagement evolving? Do you see more automated self-health management guides coming through this as well?
That's a good question. I mean, I think when anybody that's in healthcare, of course, more and more we get the self-help questions, if you will. I've been on the internet, I've been to WebMD, I'm pretty sure that I have leukemia, whatever the crazy conclusions are. So in a sense, I don't see the multimedia as being the solution to self-help. I think we always need some level of clinician involvement, and that's what I like about this. It's not patient-directed, but it's very much patient-centric with clinician oversight.
Specifically, I was thinking about chronic disease self-management.
I can appreciate that. So yes, I do see that happening, say for CHF, where, and in fact, one of the very cool things about connecting to a patient digitally, especially from a hospital, is that you can redirect that patient back to a very specific place. In other words, a specific email or a specific phone call. We send home 50, 60 patients a day from Parkview, and when we started this project a few years back, when the nurses were making calls throughout the hospital, there were over 300 phone calls to the hospital per day to the operator. Well, the patients had the operators and the patients never got any answers to their questions. So by connecting with the patient digitally and saying, as you have questions about your disease, your COPD, your CHF, call this number or email this person, and then we can help you in that. And that's exactly what our transitional care center does with these chronic diseases. As the patients call in or email back with questions, they can then send out further information about their disease, either in an email format, a text, or a video to help them better understand and manage their disease.
Great. Well, thank you again, Dr. Gogarty. This has been great. And
thank you
everyone online for joining us. I also want to take one more opportunity to plug our final symposia in the Cultivating a Network of Care series, Fostering Patient and Family Engagement. Keynote speaker is Dr. Eric Coleman, and you can get more information on our webpage as well as register for the event. It's underneath the Symposia Series tab on the right-hand side of our homepage. I hope this has been a valuable use of your time. Please keep an eye out for more information about the event in January and expanded agendas. Again, this webinar has been recorded and it will be available on the HTC website in the next few days, along with the
Kristen?
slides. Yes.
Oh, sorry. One last thing I did want to mention. On our website, Insendin.com, anybody can go there and enter their email address, and we will send you a sample care path, so you can experience it just like a patient would if you're interested.
And if anyone has challenges getting to the Insendin site or would like to shoot me an email, I can get you in contact with Dr. Gogarty as well.
Fantastic. Thank you.
Thank you, everyone. Have a great day.